Good morning. My name is Deborah Spann, and I thank you for allowing me to share this presentation about healthcare delivery with you. I'd like you to join me as we explore the microsystem elements within the emergency department at an urban medical center. This is a 40-bed emergency department staffed by board-certified emergency medical physicians. It's part of a nationwide system, has sister hospitals throughout the United States. They are a Level 2 trauma center, American College of Surgeons verified, they're a primary stroke center, Joint Commission accredited, they're a chest pain referral center, and they're in pursuit of magnet status, all which will lend itself very well to a healthy system if we can keep moving forward. Administration at this facility has actively pursued these recognitions and is in pursuit of being a primary provider of patient care. With the accreditations, verifications, designations, they've seen their patient census increase dramatically, and they are considered a premier facility in the state. Analysis of this microsystem using the 4 Ps referenced in the Joint Commission article reveals that there are many opportunities for improvement. Discharge of the patient from the emergency department is what we will focus on throughout this presentation. We know that in this microsystem, that's a very complicated process and requires diligence if we are to accomplish quality care. So thank you again for joining me, and let's move through the process. We know that leadership in this department is essential to success. Inside this facility, the C-suite leaders are all imports to the area. Unfortunately, the local employees understand that many of these people will not stay long. They're simply climbing the corporate ladder and plan to exit this facility. And so it's a bit challenging to build trust and to establish a working relationship when you know that someone is going to depart quickly. Department managers for stroke, trauma, and STEMI are held accountable for performance measures from within the emergency department, but their working relationship with the emergency department manager does not seem to be healthy. We also know that the trauma program manager wears multiple hats and is also the ICU department director. The physician colleagues are mixed in that many are very comfortable with the complex adaptive system. However, many are also obstructive and very uncomfortable working with a team approach. In the referenced article, we know that success in achieving quality outcomes is dependent on us all working together and having a seamless alignment of processes. That is not what has been found so far in this particular facility. Organizations need orientation to the goals and to have involvement from all areas if we're going to have a transformative process. We know that the establishment of the verification of the trauma center is an accomplishment to be applauded. However, not all of the components in the organization bought in. Again, as we mentioned earlier, the physician colleagues are mixed in that some of them are very obstructive to progress of the trauma center and have not engaged in integration and alignment with the processes. We know that process improvement is punitive or considered to be punitive by many of the frontline staff and by many of the medical staff. There are multiple considerations and moving pieces that have to be coordinated and guided simultaneously, but that does not always happen. Follow-up for definitive care following an emergency department intervention requires much of that care coordination and cross-disciplinary collaboration, but we have quite a few challenges. The article, Emerging Perspectives on Transforming the Healthcare System, Key Conceptual Issues, actually gives us quite a bit of information and makes recommendations that will support transformation of the system. Some of those recommendations would be that we prepare for the process change at all levels and that we identify specific goals for the organization and the microsystem and that we align those goals, develop guidelines and framework, then put our plan into action and refine our plan throughout implementation, which sounds simple, but unfortunately is not always. The patient focus at this facility is to get individualized patient-centered quality care that's delivered by professionals, and because of the advertising and marketing, they believe that that will happen. Patients with any mechanism of trauma choose to receive care at this facility and drive over many, many road miles to get to this particular hospital, trusting that they will get top quality care. Trauma care for the significantly injured and admitted patient has multiple metrics, and the staff does recognize those metrics and value them. However, metrics related to patient discharge from the emergency department are not as concise, nor are they as valued, nor do they lend themselves to the continuum of care. So we have some work to do there. Discharge from the emergency department is a time of concern for all involved. And according to the article referenced above in the discharge communication, we know that we should be able to give vital information, validate understanding by the client, clarify and teach to ensure this understanding and compliance with directions. But that's not enough. In many cases, we have complex individual needs of the patients for follow-up, and we need to have some sort of plan and metrics to measure how well we do with that. It's not just about keeping the patient's satisfactions up or clearing the bed to get another patient in. It's about quality care and seamless alignment of resources for each individual patient. So let's look at how we work together. What does it mean to complete an emergency department visit? It means that you come into triage and you are seen by a professional and you are prioritized, that you get a quality assessment by a provider. Diagnosis and decisions are accomplished, treatment given, but again, the focus of our presentation today is discharge and follow-up with definitive care. So let's talk about that. I'd like to share a story with you. It's about a 40-year-old gentleman who presented to the emergency department following a fall from greater than 20 feet. He reported pain and loss of function to the left upper arm with a noted deformity of the bone. The patient considers that his emergency department care was routine, but that he was treated excellently and received value during his time there, a valuable resource, and that the visit itself had value and the charges associated with that were as they should be. The challenge came when we attempted to get him to definitive care. The emergency department staff gave discharge instructions when this gentleman was ready to go at a little bit after midnight on a Sunday morning. He was to call the orthopedic surgeon first thing Monday. The patient did as directed, and this is where the problem started. The orthopedic clinic at 8 o'clock on Monday morning said, "Sir, we can't see you until you have been seen by your primary care physician and referred to us." They went on to say that the emergency department could not refer anyone, and then ended the statement with, "And they know that, they need to stop doing this," which again is a problem. Patient did go to his primary care, did get a referral, and then had to schedule a visit with the orthopedic surgeon several days down. When he went into the orthopedic surgeon for the visit, the surgeon said he needed more diagnostics. The patient had to schedule the diagnostic testing, go to a facility to have that accomplished, and then wait on the results. Throughout the time of waiting, which was several days, he communicated with the physician's office. He was assured that the physician had seen the diagnostic test results and would follow up to schedule surgery. At the follow-up appointment, the physician said, "Well, I was seeing your results by text, but I did not see them clearly. Unfortunately, this morning I can see them clearly, and I will not be able to do your surgical repair." So at that time, the patient had completely and totally lost his trust. He distrusted the orthopedic surgeon. He distrusted the orthopedic surgeon's staff. He distrusted the emergency department because they obviously did not know what they were doing based on the care he was being greeted with. And he lost trust in the system. We know that we can do some things to improve coordination of care, and there's a great article listed here, referenced here on this slide. But we also know that there's a lack of comprehensive information related to specific interventions or methodology that will let us accomplish safe discharge and effective follow-up, and that is something to be worked on. Before we talk about that particular piece, let's look at technology and integration, which also was a problem in this particular case. This facility has implemented quite a bit of technology, but it's not complete. And we know that from the Federal Health IT Strategic Plan Progress Report that there has been about an 89% increase in the integration of EMR in physicians' offices. This physician's office that we have spoke about did not have integration with the hospital. So we have the 89% increase across the nation. That results in about 39% of physicians' offices having access to electronic medical records and diagnostic results in a fluid manner. The problem is, for this particular patient, no one is accountable. No one owns this. The physician said, "I'm sorry, it's the hospital's fault." And the hospital said, "Well, we've tried to get the physician to implement EMR and he has not wanted to do that." And the emergency department simply said, "It is not our problem." So while we have IT and technology, we have not implemented and integrated as effectively as we could, or maybe should. The incentive for improvement at this particular facility is top down. The administrators say we're going to improve, but the frontline staff doesn't really know what we're doing or understand why. In this hospital, quality improvement is a department and not a personal effort on each individual staff member's part. The patient in this story is a healthcare provider, and he trusted the system to support his needs. He recognized that he would have challenges, but quite frankly thought that because of his contacts and his knowledge, he could circumvent any problem. That is not what happened. We know that orthopedics has become highly specialized, and there's some fragmentation, as we saw here, and a lack of access. This particular patient had to go all the way across the state to get his surgery, and it did take far too long. We also know that from the Institute of Medicine, 1 in every 14 tests is either not reported to the patient or to the clinician, or the clinician failed to record reporting the test. In this case, the results were reported, but they were very late in the event and caused a delay in patient care. We know that the emergency department discharge process is complex. There are some components of a safe discharge that have been identified. It should be, as you see here, patient-centered, collaborative, intensive. Could we use case managers? Maybe. Is more research needed? Definitely. In 2012, a group of nurses from Louisiana approached the Emergency Nurses Association with a request that safe discharge be studied and guidelines issued. The position paper noted on the slide was a result of that resolution, and it is not enough, but it's a place to start. We know that we should standardize our health teaching, but we don't know how to do that. We really have no idea where to start. We don't know what interventions work and what interventions don't. We just know that there is no formal process of discharge training for staff. On the other hand, there's great teaching for triage of the patients, but that is not where our biggest liability lays. Discharge can be improved. The professional organizations like the American College of Emergency Physicians, American Emergency Nurses Association, the American Hospital Association would top my list of places to start. All represent stakeholders that are involved, and this should be considered by them an area of high importance. We can't wait, however, on them to get started. What we could do in the emergency departments now is develop unit councils to determine what the patient, nurse, physician, and administrative personnel think about discharge and follow-up. We could do surveys of staff and patients to measure true concerns and guide staff education and process improvement. We could utilize callbacks in a better mechanism to determine compliance and understanding and collaboration, and we could certainly benefit from the use of case managers in these complex type cases. This microsystem's health is vital to the health of the entire organization. In fact, it could be said that this department is the front door of the facility, and quality care here, or the perception of quality, is of paramount importance. There are many pressures on the providers in this unit, and acknowledgement of the need for research and development of evidence-based processes to support training and competency development should be widely understood, acted upon, and prioritized to the top of the list. I've given you 2 slides for references, and I really do appreciate your time and dedication to improving the quality of health care. Thank you so much.